Welcome to the lecture series on vitamins and nutrition. So, today as a continuation from previous session, we are going to look into various aspects of vitamin D deficiency, and we are going to look into what all kinds of clinical related problems that can arise out of vitamin D deficiency. We actually left in the last session in the aspect of how vitamin D deficiency can be evaluated. So, we are going to look into those aspects. If you could get back to that understanding of what all different kinds of biomarkers for vitamin D deficiency. So, what do you mean by biomarkers? So, you look over here, there is this etiology connected with vitamin D deficiency. So, what do you mean by vitamin D deficiency etiology? It means what all the likely components that can result in a person that can eventually lead to vitamin D deficiency. That is what we mean by etiology of vitamin D deficiency. In the last session, we saw a detailed list of various causes that can be related with vitamin deficiency. For some people, there could be inherent deficiency, or maybe there is a problem connected with vitamin D synthesis. What we call it, like it could be dietarily induced, where they do not take sufficient precursors required for vitamin D synthesis, or maybe they are not exposed to sunlight. So, these are some of the components which can be avoided with lifestyle management, but definitely if there is a deficiency in diet, then we need to supplement the diet with vitamin D. In any case, there are conditions where people could be completely not aware of what kind of deficiency condition they suffer from, especially for vitamin D. In such cases, the physician can put them on a vitamin D supplementary diet. So, that is what we said. And you see the last one, in the last session we did not discuss this point. So, I would say it would be better that what kind of drugs that we already take. When I say drugs, the medicines that are being prescribed for people for a underlying condition. Let us say rifampicin, isoniazid are the two classical drugs which are given for the treatment of TB, tuberculosis. So, during tuberculosis administration, you find rifampicin and isoniazid drugs, and sometimes even drugs which are given for the treatment of seizures, what we consider as like anticonvulsants, the phenytoin class of drugs, and then glucocorticoids, those drugs which actually interfere with the carbohydrate metabolism through insulin pathway. So, what they do, these drugs cause increased degradation of vitamin D, active form of vitamin D in the liver, what we call it like 25 hydroxy vitamin D derivatives. So, liver being a primary organ for any kind of metabolism. So, for drug metabolism as well, the important lipid soluble vitamin metabolism and synthesis. So, if liver could be indirectly made a impact, could be made to have an impact on metabolism, that would directly affect the way in which the vitamins are synthesized and utilized in the liver. So, that is the last cause. What we say, what we call it, like I think in your session series you do have a separate study on drug interaction with vitamins and drug interaction with food related substances. This is one such classical example where a drug induced increased metabolism in the liver could directly affect degradation of vitamin D active components or metabolites. Okay, so, you see over here, and as I have told you, there could be some underlying disease. Let us say a person is suffering from hepatitis B or hepatitis C or D or hepatitis A, various classes of hepatitis connected by serological differences in the viruses. Some are really deadly and some are treatable and some are reversible, and in any case, all when it leads to hepatitis, liver disease, any person suffering from liver disease needs to take additional supplement of vitamin D. So, for that matter, as a nutritional biochemist or a person who is concerned to be a dietitian, or all those professionals who are involved in food related clinical applications or clinical supportive therapy, or even I would say people who are involved in caretaking for dietary supplements for chronic diseases needs to be aware of this, and all physicians obviously are well aware of this, and it is part of their training to determine the cause of a disease. So, any symptoms should be distinguished between a classical disease and a disease caused by vitamin deficiencies. So, what a physician would look for or what a dietitian would look for. So, these are some of the things that you could always look as a positive indication for vitamin D sufficiency. So, the first one being you assay the amount of 25-hydroxy vitamin D active components, okay, parathormone, then you have bone mineral density being done, then fractures and falls, intestinal calcium absorption. You can always look into how much amount of calcium is being absorbed across, then blood pressure is an indication, dental health, then insulin sensitivity, beta cell function, closely associated with insulin sensitivity. So, there is a little difference when you say insulin sensitivity and beta cell function, because in insulin sensitivity insulin could be secreted, but probably the insulin is not recognized in the insulin receptors, whereas beta cell function relates more to type 1 diabetes, where there is no sufficient amount of insulin produced by the person. Then immune function, I mean an erratic immune function, respiratory diseases, you say wheezing, symptoms like pulmonary insufficiency and all those symptoms. So, it's like you may have individual symptoms, you may have a collection of symptoms, whatever the case, the physician or the dietitian should be mindful and try to relate this with probably the history, the dietary history of the individual, the drug history or the medical history of the individual, and try to ascertain what kind of vitamin D sufficiency they suffer from. Sometimes you could even have a masking syndrome. Let us say they already have a history of wheezing or respiratory disease. This could get worse in the context of vitamin D deficiency, or let us say they already suffer from blood pressure related complications, erratic blood pressure, too high blood pressure. Suddenly you see a person who is suffering from blood pressure, generally on a therapy of hypertension, antihypertensive drugs, and suddenly you find their blood pressure erratically drops down. So, this could be a reason of vitamin D associated calcium deficiency, and maybe the physician trying to just fix up only the dosage of antihypertensive drug would not really help the condition. In such cases, reducing the drug will not only create a rebound hypertension, but overall there could be more erratic cardiac functions happening. So, these things should be monitored through differential diagnosis. What do you mean by differential diagnosis? You just check up the diagnosis not only for this classical diseases, but also you look for individual symptoms and see whether it is something like you say you create a kind of a checkerboard list, you say positive, negative, you just take a click and you see which would be the exact cause. You do a kind of a weight analysis, you just weigh which one would be right and which one would be low as far as the symptoms are concerned, and then finally narrow down to vitamin D deficiency. So, in any case, if you consider look over here, even the dental health is an essential feature, because for some people, especially for children, dental hygiene can be associated with vitamin D, maybe thinning of teeth, okay, and frequent dental caries could be a reason for vitamin D deficiency. It is true, children who gobble upon lot of sweets and sugary components trying to create a base for plaque formation, but maybe children who do not have such habits still suffer from dental caries, then we need to look for a cause connected with vitamin D deficiency. So, here again one more point, what we consider as BMD, bone mineral density. So, this is one of the best tests to do to determine people to know what kind of mineral density their long bones have. This is a kind of a mandatory test prescribed for people past age 45 for women and for men past age 50, and mineral bone density not only helps us in predicting what kind of osteoporotic condition the person is suffering from, because if it could be due to calcium deficiency and calcium deficiency associated with vitamin D deficiency, or probably it could be any kind of cancerous lesions in the bone. In all such cases, there would be variations in the bone mineral density. So, bone mineral density will give you a kind of an objective result, and then you relate this with the clinical symptoms already the people have and cross diagnose with other conditions, and through that you would be able to ascertain whether this is due to vitamin D deficiency or due to some other illness, underlying illness over there. So, we are going to look at, so when you need to order for. So, these are two tests which are generally recommended, what we call it like checking the levels of vitamin D in terms of 25 hydroxy vitamin D component or metabolite in circulation, and also to order for 1,2,5 dihydroxy vitamin D test. So, these are the tests, and this is one format for the test. There are many commercial formats available. I have pulled out a commercial format. This particular commercial format tells you that there is this sample of blood serum taken, and you try to evaluate the amount of vitamin D. So, this can be done in different formats. The format what we have over here is basically a blend of calorimetric and immunogenic format. So, in a calorimetric format, you look into the absorbance of vitamin D and you try to extract vitamin D or precipitate vitamin D from the serum concentrations, and then try to spectrophotometrically evaluate a calorimetric assay, and then you create a linear plot, and from the known concentration of the standard given, you try to find out the concentration in the samples that you are trying to evaluate. That is one way of doing it. In a immunogenic based tests, you can have vitamin D specific antibodies available raised in a animal system, and you can create a sandwich ELISA format where the antibodies raised again, it could be monoclonal or it could be polyclonal. You coat the plate with those antibodies which are specific for vitamin D, and vitamin D being a small molecule, you might wonder how it could be possible to generate antibodies. Yeah, there are bioconjugate technologies available. So, what they do, they conjugate with kind of an aptan. The small molecule vitamin D can be conjugated with an aptan, and aptan is a substance which does not actually provoke any immune response. But when you conjugate this with vitamin D, the chances of making vitamin D specific antibodies would increase in the host. So, what they do in a mice system or in any animal system, they will make a conjugate of vitamin D with the aptan carrier molecule. They will do a covalent conjugation, and then they will immunize the animal. Now, in this case, if we have to take example for a mice, you immunize mice and then you raise antibodies. So, these antibodies can be collected as such as monoclonal antibodies if you want or interested for it, or you can create a polyclonal sera, and as you do, it's a kind of a sandwich ELISA format. So, what you do in a sandwich ELISA, you coat the plates, okay, with the antibody, then you take the sera sample which is supposed to contain vitamin D, and then you add it, and then you add the primary antibody, and then you have a detector for the primary antibody, and then you do an ELISA format. So, in a ELISA format, so this format what we are looking over here is basically a kind of a format where you look for calorimetric evaluation coupled straight away or through a ELISA based format. So, when the color develops, you are sure that there could be vitamin D components present in the sera. Now, how do we quantify, because that is what we are interested in. So, what you do in this case, we have to develop a quantitative ELISA where known concentrations of vitamin D are added and a plot is made, concentration versus OD, amount of absorbance that you could get based on the amount of vitamin D present in the sample, and there could be a linearity graph created, and through that we will be able to extrapolate and find out the concentration of unknown samples which contain unknown quantities of vitamin D. So, this is a very good way of doing it, and immunogenic based ELISA methods are more accurate, and you do have calorimetric tests as well. So, in any case, only when you really know the concentration of vitamin D in a person's sera, you would be in a position to really know for sure, because whatever that we have seen so far would give you a very good indication, biomarker for vitamin D sufficiency. So, you take into consideration all these symptoms, but checking up the concentration directly of vitamin D is of profound significance, because if checking for vitamin D, you know for sure, you are like really checking up, like you do check for sugar, you check for cholesterol, you directly evaluate biochemically the concentration of vitamin D. So, that is a very nice system. There are other tests as well. I have not shown those tests over here, but you can always understand and study, especially bioassays. Normally they take vitamin D and they do in vitro cell culture studies, but these tests are more of research oriented evaluation rather than on a routine bench based assays on a clinical laboratory on a day-to-day basis. So you see over there, so what exactly these results mean? So when you have a low blood levels of vitamin D, so that's the indication. So what you could expect? So you could expect a low level bloods not getting enough vitamin D. Okay, so you could consider it could be a problem with absorption. Maybe the person, you look into their medical history and let's say you find the person is suffering from celiac disease, okay, or cystic fibrosis, or maybe they already have a history of biliary obstruction or a jaundice connected with biliary obstruction, then yeah, you can be for certain sure that this person is running down of vitamin D. So in such cases you could recommend directly prescribing I would say parenteral dose of vitamin D, because intestinal absorption is like creating a problem. So you could recommend a weekly dosage of vitamin D through parenteral route. That will be the best way. And suppose if you could high levels you find, then you could always go back and look into their medicine history, what medicines they have been taking and what nutritional supplements they have been under, and then you can ascertain. And this, as I told you earlier, like vitamin A could be a reason for hypervitaminosis, and hypervitaminosis is also not a healthy condition. It can lead to severe pathology. So either way, either low level or either high level, and you can repeat these tests after whatever intervention that's been prescribed, and then look for whether the levels have come to a normal range. So here it is, we have deficiency. So when you consider it to be like typically deficient, when a person is being diagnosed as typically deficient for vitamin D, so you see here nanomolar per liter, so you have less than 25 nanomolar concentration, you see like deficiency. So if you are in a range of 25 to 50, so you see you have to immediately take a replacement of vitamin D, because already there would have been damaged costs for the tissues. So in such cases a parenteral administration would be the best option, and followed by maintenance therapy, probably weekly or monthly, and you can set a time schedule. And in case with insufficient, so you see the range is between 25 to 50. So in this case you have to look at other conditions. You see whether they have been on a concomitant administration, I mean taking simultaneously some glucocorticoid, or they already have osteopenia or osteoporosis related conditions. Then you check for what conditions they have and try to supplement. Then you do have conditions where the range is above like 50. Okay, you say this person is being sufficiently fed with vitamin D and no need to continue for any dose, and you can say the person would do healthy with the diet, whatever options that they are into, and you have to recommend that whether they ensure a maintenance of this dosage so that you can have a healthy concentration over here. Then if you find more than 150 nanomolar, then it's like really a problem. Then you have to like really consider, you have to stop the therapy of vitamin supplementation, and you see, yeah, you monitor the calcium levels, because sometimes an higher intake of vitamin D can actually create dangerous levels of calcium in the system, in circulation, and this leads to unnecessary calcification and nodule formation and calculi formation in the renal tubule and so on. So then in such cases you don't supplement with any of these diets, and then you simply replace or you simply stop with the maintenance therapy, and you could allow time for the body to recoil and get adjusted to the normal concentrations of vitamin D. Now we are going to look at one more condition. So this would be an expansion of this symptom, this table, whatever we considered here. So you might wonder what this table has to offer. Now we are going into the details. Okay, so you see, yeah, this one we have already seen. This person is like being deprived of sufficient sunlight, or maybe they suffer from certain aging condition, or maybe heavy skin pigmentation and so on. Then the second reason, the most common reason being malabsorption or obesity. Then you do have nephrotic syndrome and you have concomitant administration of drugs mediated through liver. Then you have typical liver failure, maybe hepatic diseases, and then you have other conditions what we consider as X-linked hypophosphatemia, or you say hypophosphatemia connected with other conditions, or oncogenic osteomalacia. So you need to like really look at how an underlying cancer or a condition can give rise to these complications in vitamin D deficiency. Now we are going to look into the clinical signs of vitamin D deficiency. So if you look at this picture, I think in the previous session I showed you this picture of how rickets and osteoporosis would be the classical symptom of chronic vitamin D deficiency. See, chronic vitamin D deficiency, when the person is not being supplemented with vitamin D for a very long period of time. So if you ask me how long, it depends on an individual, how their system would cope up, how their physiology would respond, but eventually if their condition is not corrected, then this gives rise to rickets and gives rise to osteoporosis and osteomalacia. Okay. So now we are going to look at vitamin D deficiency. So we have already seen in osteomalacia. So osteomalacia is the most simple version of deficiency. You say malacia is like soft. So it's basically a metabolic bone disease. It means what? As I told you in the last session, that bone is a dynamic organ. There will be calcium release and calcium deposition. So this is kind of a lively way of how calcium reserves in circulation can be monitored, and bone being a primary organ or acting like a kind of a reservoir would be able to do it. So now if you go further, there could be other conditions, as I have told you earlier. See, I have mentioned some more stuff like chronic diarrhea, pregnancy, then drugs on certain concomitant administration. Some more examples I have given here: Dilantin. Previously I mentioned about phenytoin, and we also looked at isoniazid and rifampicin related drugs. Here we have one more anticonvulsant drug being mentioned. Now look over here. So how exactly this osteomalacia would be diagnosed as a clinical symptom? So the person would find it very difficult to adjust himself raising from chair, probably if they are sitting in a chair, and difficulty in walking, problems with coordination would be there. Then there would be, I would say, persistent myasthenia, what we call it like muscle weakness. The word what I have told you right now is a technical word, which means myo means muscle and asthenia means feeling, and myasthenia means a kind of a progressive weakness in the muscle and accompanied by low back pain. So all the supportive spinal structures are being deprived of calcium, so they find it very difficult to cope up with any mundane activities of the day. So they quickly develop low back pain. See, don't associate these symptoms with people who already have osteoarthritic conditions. That's always there, and they also have the symptoms of low back pain. What I am trying to say, in vitamin D deficiency associated calcium deprivation, these symptoms could be there, and these symptoms, when properly addressed and can be treated and can be completely reversed over a period of time. Whereas if there is a degenerative change already set in, then maybe we could reverse the condition, and depending on the age, how the person would respond would also vary. So look over here, the diagnosis, as I have been telling you. So you see there 25-hydroxy vitamin D you look for, and here something very interesting to note, alkaline phosphatase. So what is this alkaline phosphatase has to do over here? So alkaline phosphatase is a liver enzyme. So alkaline phosphatase is an indication of inflammation, it's an indication of liver disease conditions, and you see biochemically, when you look for an elevation in alkaline phosphatase accompanied by a reduction in calcium and a reduction in serum dihydroxy vitamin D derivative, the active form, then you can be like sure that this amounts to something to do with vitamin D deficiency. So you see over there, this is very interesting observation. Can you see over there? See the bones getting thinned out, kind of a bow shaped formation sets in. So you see it's like getting detached. You could see junctions of decalcification. This is an indication for porosity. And look over there, the classical rickets. So you see the normal anatomy, how the bones are straight and the bones are able to cope up, and you see the mineralization, the desorption of the bone, and you see the desorption makes the bone kind of snap and flux. I won't say like snap crack. If they snap and crack, that will be the case for adults because the bones have been already calcified, but for children and for young adults, since this is what we call it like hypophyseal end, the tips of the long bones, and tips of the long bones seal the fate of a bone as they are growing into adulthood, would make the bone very solid, allowing more calcium to get deposited. Doesn't mean that the bone have gone dead, the bone have become solidified to bear more tough tasks at hand. But for children, the bones are flexible, and in that state, if you are going to like desorb the calcium, deprive the bones of calcium, then you have this what do you say, kind of bow shaped bending of the bones occur. So you see there, rickets is a consequence of vitamin D deficiency and may occur due to calcium and phosphorus metabolic disorders. One thing I want to mention, so vitamin D, whenever we are talking about vitamin D, this ricket symptom what we saw just now, and we have been discussing about it for since last session, you have to always be very sure it is all a dual I would say function, vitamin D, calcium and phosphorus. So I think we'll do a quick recap. So in this session we were looking into the details of the etiology of vitamin D deficiency, and we were also looking into the preliminary major symptoms associated with vitamin D deficiency, and we primarily dwelt on the diagnosis of how to determine vitamin D deficiency. Thank you.